got a new computer and a new webcam, so I'll record it with my webcam, and that's what I'll make the YouTube video out of, and send that along as well. So we'll have backups to our backups even after tonight. So definitely excited about all that. Well, last time we got through the lymphatic system, and we were getting ready to start the chapter on cancer. And one of the things that probably everybody has heard of is cancer, and you probably know somebody who's been affected by cancer. But what really is cancer? And it's unfortunate that so many people get affected by this, but yet they don't fully grasp what exactly it means to have cancer. And what I'm going to do is get my marker board, and we're going to talk a little bit about cancer. And cancer is going to be a rampant, uncontrolled growth of cells. And under normal circumstances, under normal circumstances, cells are going to follow a hierarchy of development. And this hierarchy of development is going to tell them that at a certain time, they're going to divide. And then a certain time after that, they're going to divide. And that's how we make millions upon millions of cells, even trillions of cells that we're made up of as an adult. And that information is all, of course, contained within our DNA. In our DNA, if we were to break it down, there would be little stop codes that tell our cells, okay, you're going to go through one cell cycle, two cell cycles, and then after that, you're going to stop dividing. That's what a normal cell does. But cancer cells, they don't play by the rules. So even though we have these little stop codes and it says maybe after two cell cycles, you're going to stop dividing, cancer says no. We're just going to keep right on dividing. And those cells, they don't play by the rules. They just continue to divide and continue to divide. And they will take oxygen-rich blood from other tissues, robbing it of vital nutrients necessary for growth. They will also potentially spread. They'll get into the lymphatic system. They can even get into the blood and then spread throughout the entire body. That's what we call a cancer that has metastasized. Metastatic cancer means maybe it started in the lungs, but now it's spread by the lymphatic system, that set of vessels that we talked about last week. It's now spread to all parts of the body. Remember the great cyclist Lance Armstrong? Of course, he got a lot of bad publicity there for his steroid abuse and other doping techniques. But of course, he was a cancer survivor. And his cancer started out as testicular cancer, but it ended up manifesting as cancer of his lungs, as well as making its way to his brain. So here they would have found cancer cells that were testicular cancer cells at that, in his lungs and in his brain. So again, that's how cancer metastasizes, and it does it because it just doesn't follow the rules that our normal cells would follow whenever they're going through their cell cycles. They listen to the DNA. Cancer cells don't. And that's what makes cancer so devastating. It will rob other cells. It will infect other cells too. And when it migrates and gets into other parts of the body, it starts to uncontrollably divide, just like it did where it originated from. And so that's what chapter 20 is about. And since this course is a lot of anatomy and physiology going hand in hand with the associated medical terminology, we're going to learn about cancer, and we're also going to learn about the elements that make up words associated with cancer, the prefixes, roots or combining forms and suffixes that are often seen in a patient's medical chart that let you know that this is related to cancer or oncology. And so in our McGraw-Hill resource, and I hope everybody got the video. I thought it was a good idea to kind of share a little bit more information about what that resource can do. And by all means, use the LearnSmarts. They are very intuitive. They actually pick up on what you're having trouble with, and they'll ask you more questions and highlight that particular information as you're going through the reading, and it'll have the little coach pop up and tell you, you've been reading for a while and you need to practice some. Let's practice. And so again, it is a very helpful tool. But cancer, again, following along in chapter 20 of our medical terminology textbook, it's malignant. And again, malignant means that these cells are in fact cancerous. Now, the flip side of that is going to be a non-cancerous cell, which we would say is benign. Benign cells may grow larger than normal cells, but they're not cancerous. Okay, they may impinge upon other people's, other cells, but they are not cancerous. And so that's important that we know the distinction. So going along with chapter 20, and we talked about, here's figure 20.1, we talked about cancer metastasizing, and I gave you the example of Lance Armstrong, how his cancer started in the testicles and then moved throughout the rest of his body, his lungs, and his brain. Well, in 20.1, we see the same thing. We see the primary tumor is in the breast, but it has metastasized throughout the body. It's in the bone, it's metastasized to the lungs, it's in an axillary lymph node, and so ultimately that cancer moves throughout the body, and that's why it can be so damaging. Now, one of the things about the benign cells that it says here in the text, they grow slowly. Cancer cells grow rapidly. And the reason they can grow rapidly is because they take all of the nutrients, all of the oxygen, and use it for their own good, while the other cells in the region get starved of oxygen and nutrients. Okay. Another neat thing about benign tumors, they're surrounded by a connective tissue capsule, so that basically keeps them in a tight little package. And benign tumors, for lack of a better way to put it, are a lot easier to scoop out than what a cancerous tumor is. For example, if we had a cancerous tumor, let's see, make sure we can see well here. If we had a cancerous tumor, and let's say it's a tumor of the breast, okay? And ladies, please don't laugh. But if this is the breast cancer, if this was a benign tumor, a surgeon could simply cut right around the edge of the tumor and take it out because it is encapsulated. But on the other hand, if it's a malignant tumor, and again, here's the tumor, here's the areola, the surgeon doesn't go in there with a scalpel, so to say. They practically have to go in there with a broad knife and take it all out. So all of the tissue ultimately that potentially could be infiltrated by the cancerous cell gets removed. And that may include the areola, all of the fat or adipose tissue, all the ducts, all the lymphatic structures, the lymph nodes, the lymph vessels. So ultimately, all of those may have to be carved out. Now, keep getting something here about wanting to I have to reformat the recording of this meeting, so that's what's popping up on my screen right now, getting in my way here. Okay. Now, benign cells don't infiltrate adjacent tissues, they don't spread into other organisms or lymph nodes, and they can compress surrounding tissue, causing functional structures, but again, they don't spread throughout the body the way metastatic cancer cells do. Now, we scroll down a little further in chapter 20, we see in the United States the three most common causes of death are cardiovascular disease, cancer, and cerebrovascular disease, primarily stroke. But again, cardiovascular disease and cancer, very, very prevalent in this day and age. Now, some key terms. Benign. Benign is a medical term, okay, which is Latin, and it's denoting non-malignant character of a neoplasm or illness. Cancer comes from the Latin term crab, which of course is one of the reasons why people hear that horoscope word, cancer, and it has a connotation with that as well, because it has the sign of the crab. It's a general term for a malignant neoplasm. Cancerous means pertaining to malignant neoplasm. OUS is a suffix that means pertaining to, and CANCER is an element, the root, that of course means cancer. Infiltrate, ate at the end means composed of or pertaining to. Okay, in means within, and then filter means strain through. Okay, infiltration is the actual process of infiltrating. Malignant, malignant. It's Latin for hurtful. Okay, capable of surrounding invading tissues and metastasizing to distant organs. Malignancy, malignancy. It's a state of. ANCY is a suffix that means state of. So that would mean state of malignancy or state of being hurtful. And then malign means cancer. And that's another combining form that means cancer. And there are several of those. Onco, onc with the combining combining vowel O. Cancero. All of those mean cancer. Metastasis. Okay, metastasis. Scrolling down our list here. Meta means after or beyond. Stasis, stay in one place. Ic means pertaining to. And then stat means stand still. So metastasis, metastasis, and then metastatic, all of those mean the spread of cancer. Then we go down to neoplasm. Neoplasm. Neo means new, and you can think of that as new growth. Neoplastic, okay, pertaining to neoplasm, and then neoplasia, process that results in formation of a tumor. Okay. The next group, oncology and oncologist. Logi, we've already talked about numerous times. Logi means study of. Onco means tumor. And then logist, one who studies or a specialist. And oncology is the science dealing with cancer. And an oncologist is the medical specialist in oncology. Proliferate. Proli is bear offspring. Okay. Fair, the suffix fair is bear. And then ate is composed of. So to increase the number through reproduction. Okay, to increase the number through reproduction. And to proliferate just means that the cells start in one area and then they multiply and spread throughout surrounding healthy tissue. Then finally, tumor. Okay, tumor, Latin for swelling, any abnormal swelling. You could say that somebody has a blood tumor, a hematoma, and that would be a swelling. Okay, if I'm walking through the living room and that coffee table just jumps out of nowhere and hits me in the shin like they always seem to do in the middle of the night, and I sit down and start rubbing my shin, very quickly I can feel a hematoma forming, and of course that's going to be a blood tumor or swelling. Now, scrolling down a little more in our McGraw-Hill resource, our different types of cancer, we've got several classes: carcinomas, sarcomas, leukemias, lymphomas, and melanomas. Carcinomas are epithelial. We have four main tissue types. We have connective tissue, muscle tissue, nervous tissue, and epithelial tissue. So carcinoma is going to be a cancer of epithelial tissue. Cervical cancer, stomach cancer, squamous cell, skin cancer, and lung cancer are all types of epithelial cancers. And when we think of epithelium, think lining and covering. Epithelial cells line hollow tubes or they cover. Like, for example, our skin. That's epithelium. If we had the lights just right in here and I would do this really rough, you'd see a bunch of dead skin cells sloughing off. Those are epithelial cells. Then sarcoma. Sarcoma is a cancer of connective tissue, bone, cartilage, muscle. Osteosarcoma, chondrosarcoma, rhabdomyosarcoma, all of those are cancers of connective tissue, bone, cartilage, or muscle. Those are the forms of connective tissue. Leukemia. Leukemia is going to be a cancer of blood-forming tissues. We have acute lymphocytic leukemia and chronic myelogenous leukemia. Those are all different types of cancers dealing with blood-forming tissues. Then lymphomas, they deal with lymph nodes. Okay, lymph, we've already talked about the lymphatic system. And so oma, again, is going to be tumor. And so now we have a cancer of the lymph nodes. Hodgkin's disease, non-Hodgkin's lymphoma, those are both types of lymphoma that we will hear commonly. And then melanoma, melanocytes, melano means brown or black, and melanocytes are going to be in our integumentary system, our skin in other words, and they're what are going to protect us from UV radiation. UV radiation, of course, is the radiation from the sun, and if I go out in the early part of spring next year, since we're heading towards fall, and it's been months since I've been outside and really had any sun, and I go out on the first nice spring day and I walk my dogs and I play with them and so on and so forth, then I'm likely to get too much sun because I don't have my melanocytes producing enough melanin because they haven't been exposed to any UV radiation in quite some time because I've been covered up all winter. On the other hand, if I just went out for a few minutes at a time and gradually allowed those melanocytes to produce enough pigment called melanin to keep up with the amount of exposure I have to the sun before I went out for any great length of time, then I would get tan.
Yeah.
Okay. All right, let's continue to move forward in chapter 20. Oh, did I skip too much? Okay. In our chapter, carcinogenesis, the term carcinogenesis, this is 20.4 learning objective. And just as the definition says, it literally means creation of cancer. Carcino, we've already talked about as a combining form that means cancer. Genesis means formation of or creation of, like I said before, just like in the Bible. And so ultimately, carcinogenesis is the formation of cancer. And so let's scroll down a little bit farther, and it's going to talk about our terms that are commonly associated with the formation of cancer. The first term is apoptosis, and apoptosis is the programmed normal cell death. When I drew my little diagram up on the board and showed cancer cells not obeying the cell cycle, okay, they were no longer programmed properly, and so those cells did not go through apoptosis. After a certain number of cell cycles, a cell should die off automatically. Cancer cells, like I said, do not do that. They don't follow the rules. Carcinogen, carcinogenic, and carcinogenesis, all of those are terms about creation of cancer. Carcinogen is something that produces cancer. For example, people who work around industrial chemicals like benzene, for example, that may produce a form of cancer. Carcinogenic is something that causes cancer, pertaining to the production of cancer. And carcinogenesis, as we said a minute ago, is the origin and development of cancer. Mutagen, an agent that produces mutation in a gene. Cancer is all about mutating our genes. Most cancers are not passed down from the parents to the offspring, but that doesn't mean that cancers all don't have some sort of an origin related to our genes. What that's saying is if I'm out in the sun too much, like we talked about a few minutes ago, that amount of UV radiation on a regular basis can actually lead to mutation of my DNA, which is what gives me skin cancer. So that's what we mean by something that's a mutagen. It's some sort of an agent that produces a mutation in our genes, and when those mutated cells go through that cell cycle, they may not quit reproducing, and that could lead to the cancer. Now, it doesn't have to be just UV radiation. It could be nuclear radiation. It could be something like the carcinogens in cigarettes that lead to mutation of our genes. Again, industrial chemicals like benzene. Those are all examples of outside environmental type forces that lead to mutation of our genes. The next two terms, oncogene and oncogenic. An oncogene is a family of genes involved in cell growth that work in concert to cause cancer. Okay, cancer again is going to be related to our DNA. It may not be something that mom and dad passed down to me, but nevertheless, it is the result of a mutation of our genes. And so oncogenes are those multiple genes coming together which ultimately produce the cancer. Oncogenic, capable of producing a neoplasm. And when I think of a neoplasm, again, I kind of use tumor and malignant tumor and neoplasm and cancer, all of those kind of interchangeably. But if something is oncogenic, it can produce a new neoplasm. Okay, and again, that's going to be new, rampant, uncontrolled growth of cells. And proto-oncogene, a proto-oncogene, a normal gene involved in a normal gene involved in normal cell growth. That's just going to be our genetic material, our blueprint that makes us who we are, telling our cells when they should grow, how big they should grow, and so on. We got multiple factors in 20.5 learning objective that can lead to cancer. Environmental pollution. Pollution is a trigger of many cancers. Cigarette smoke, for example, would be a form of pollution. Radon is due to the radioactive decay of uranium that can be found in people's basements. It's actually the second leading cause of lung cancer. Air pollution can lead to lung cancer. Chemical toxins, chlorine, PCBs, polychlorinated biphenyls, pesticides can lead to cancers. Dioxins, asbestos, arsenic, all of those can lead to cancers. And of course, prevention of cancer, lifestyle modification, a big way to prevent cancer, stopping smoking, exercise, eating a lot of fiber, foods that are high in fiber, like raw vegetables, raw fruits, all of those help to scrub out our colon and keep us from having digestive related cancers. A comment on that, um, fiber is carbohydrate in very, very long chains, but we can't digest fiber. But the beauty of fiber and why it's so beneficial in our body is the fact that the fiber can't be digested. And if this is a tube of our gastrointestinal system, the fiber acts like a scrub brush because it is kind of rough, it can't be broken down, and anything that doesn't get fully digested leaves in our fecal material in that mass of undigested fiber. And that's what helps really clean out our gastrointestinal system. So when people eat a lot of processed food and they don't take in enough fiber, a lot of fruits and vegetables in their raw state, or any other types of whole grain products and things like that, then they are much more susceptible to various forms of cancer. And so, again, a lot of cancers are preventable, or at least we can minimize our risk. Okay, and these were just some of the various agents which could potentially cause cancer: chlorine, dioxin, environment, of course, that's all the conditions outside of the body. Okay, environmental pertaining to the environment, flavonoid, pigment found in fruit, wine, and tea, particle, small piece of matter, particulate, very fine particle, pesticide we talked about. Those are used for destroying various insects for our crops. Pollution, condition that is unclean, impure, and a danger to health. Uranium, it's an element, and its decay is what produces radon gas. And detection of cancer. Well, breast cancer is a form of cancer which we hear a lot about. There's the Komen Foundation for Breast Cancer Awareness and such. And self-examination by females is something that is very important. It needs to be stressed by physicians. It needs to be stressed by all healthcare providers. And females can be taught how to perform breast self-examination through palpation. Palpation means to touch. We use our tactile receptors in our skin to feel different things. And females can detect lumps in their breast. And of course, that's a monthly breast self-examination. In men, especially men over 50, prostate and rectal examinations are going to be important for preventing these forms of cancer. It mentions a DRE, a digital rectal exam. These are our digits. So a digital rectal exam is going to be where the physician tells the patient that I'm going to have to use my finger to detect any kind of deformity in the rectum and in the large colon. So again, that's a test that a physician could perform on a male on a regular basis to make sure that they don't have any early developing cancers of their gastrointestinal system. Melanoma, self-examination of the skin, performing the ABCD test. The ABCD of skin cancer is asymmetry. Do both sides look the same of the area that is in question? The border, is the border all the way around, and is it even? Okay, or in cells that may in fact be cancerous, the border is broken and it's not even. Okay, the color, is it, just one color like brown, or is it brown and purple and blue, red? Multiple colors are definitely something that could spell cancer, skin cancer. And then finally, diameter. Is it the size of the end of a pencil or pen? If it's bigger than that, then it's, again, something that needs to be checked out. In females, Cervical cancer is obviously a common form of cancer, the female reproductive system, and should be tested for on a regular basis. Females should have their yearly gynecological visit and have a pap smear test performed. And now they're also talking about, because so many forms of cervical cancer are related to the human papillomavirus, that there are vaccines now for HPV, and even very young girls and boys in their early teens are, being cautioned that vaccination is something that they should seriously consider, or their family should seriously consider on their behalf. Breast cancer screenings, mammograms, of course, like the lady in the picture is having performed. Digital mammography, okay, uses X-ray images, and those X-ray images are going to be, the data is going to be collected by a computer and images created. Computer-aided detection, okay, a laser beam converts its digital signal and it's picked up by a computer to highlight suspicious areas. MRIs, magnetic resonance imaging, it uses the magnetic field created by two magnets to create a picture on a computer. Laser guided breast biopsies, again, that's going to be using a stereoscope to help the physician determine if there are masses in the breast, which could in fact be malignant. And then stereotactic guided biopsies. Stereotactics are, sometimes you will hear the Gamma knife. That's a form of cancer treatment that uses a very focused amount of radiation. And the stereotactic guided biopsy is basically similar to that. Ductal lavage collects samples of cells from breast ducts for microscopic analysis. Okay, our word bank, digital, pertaining to the finger or toe. Lavage means to wash out a hollow cavity. Mammogram, mammo means breast. Okay, the record produced by an X-ray imaging of the breast. Mammography, the process of X-ray examination of the breast. Progenitor, founder or the beginning of ancestry. Progenitor is typically, in terms of anatomy and physiology, the cell that originates. So maybe we're talking about the original cancer cell was a cancerous, or excuse me, was a cell of the testicles, like for example in Lance Armstrong's case, and the progenitor cell was a testicular cell that mutated and produced itself without dying off through apoptosis, and that's what led to a malignant cancer that spread throughout the body. Radioactive, spontaneously emitting alpha, beta, or gamma rays, like the depletion of uranium as it starts to decay, radon gas gets emitted through its radioactive decay. Self-examination, examination of one's own body part. In the males it might be testicles, and the female it might be the breasts. Okay, lung cancer, and how do we detect it? Well, going through our chapter here in the McGraw-Hill resource, chest x-rays are one of the ways in which lung cancer may be detected. They may also use computed tomography scans to detect cancer, often called just a CT scan. Positron emission tomography, it's another type of cancer screening tool. Magnetic resonance imaging, again, uses magnetic waves to create a picture and determine if cancer is present. Scintigraphy, okay, uses low-level radioactive agents that bind to cancer and can be tracked by special cameras to reveal the location of cancer cells. Bronchoscopy, okay, that's going to be a scope that is used to look at The airway passage is called the bronchi. Bronchoalveolar lavage, a washing process that is going to wash the small air sacs at the end of the bronchi. Needle biopsy, that's for tumors of the periphery of the lungs, is performed by inserting a needle between the ribs and guiding it to the tumor by fluoroscopy or CT scan. The biopsy, it says, can also be performed using thoracoscopy. That's going to be using a scope that obviously is going to be in the thoracic cavity, which is the chest. Mediastinoscopy, okay, uses a fiber optic tube with a camera inserted into the mediastinum, and that's in this region right here, okay, via the suprasternal notch. Sputum analysis, just as the name implies, sputum is going to be secretions from the respiratory passageways because we are talking about lung cancer, and sputum analysis will be able to detect if there are cancerous cells. Oops. Biomarkers. Yes. Yes.
You doesn't always detect cancer cells. Sometimes when they do the sputum cultures or whatever, they don't come back with the diagnosis of cancer cytology. Then they have to go in and do take out some tissue.
Correct.
Why is that?
A lot of it is just going to be due to the location. If it's, for lack of a better way to put it, the mucus secreting cells that would ultimately be what creates the sputum, if the cancer is not close to that layer of the epithelium, then it might not be detected in a sputum sample. If the cancer is in the more deep tissue, then it may just not be picked up. And that may be where they would need to do some sort of a more invasive test like a needle biopsy. A sputum test would probably be more of a minimal invasive, and it would be a broad screening tool. It would catch, let's say, 50% of the cases or something along those lines. But if there were other discerning factors, then the physician would probably want to investigate a little more deeply. If the patient was still having some other signs and symptoms, they'd probably want to do more testing just to be certain and not just go by the sputum analysis.
Oh, that's good to know because sometimes someone will want to think,
Mm-hmm.
why not?
Right.
And when you're doing cancer, when you're abstracting cancer cases, you cannot use the sputum or cytology if it's even if it's positive. The definitive one that they want to use for the biopsy.
Right.
But I have a question for you. Let me come closer because this is very important. We had an audit here in this department where the coders got tagged on bronchoscopy
Mm-hmm.
and a lung biopsy. So the coders had picked it up as a lung biopsy, but when we went back and we talked to a compliance, now we went back and we talked to the people in the lab or down in that area that do that, they said no, it can't, just because they say you have a bronchoscopy and a lung biopsy, it's not really a true lung biopsy because it didn't go through one of the cavities. Can you sort of clarify that where that lung tissue is located, and if they're just going in and doing a bronchoscopy and do brushing, that's not the same thing as the actual lung, because they have to go through that wall, right? Or
Right.
cavity to that lung tissue.
Right. What they might have to be.
Just another thing, and I'm asking you to explain that because the department is going to go under, the coders are going to be re-audited. So for the participants here, if you can give us the benefit of really explaining that difference, then that would help us immensely.
Sure. Okay. Okay, this is your trachea, and it's going to divide into two more sets of tubes. And this is your left bronchi, and this is your right bronchi. Those are going to divide even more into smaller tubes called bronchioles. Well, those tubes are going to go into our lungs, and the lungs themselves are not two big balloons, but instead they're made up of millions upon millions of tiny little air sacs called alveoli. And those alveoli give the lungs tremendous surface area. And because we have to get oxygen from these tiny little air sacs into the bloodstream, the alveoli are actually surrounded by capillaries. A net, a meshwork, forms around the capillaries, and the alveoli and the capillaries actually share a cell membrane wall. And so when we have these very tiny air sacs compromised in any way, shape, or form by, say, cancer, well, there is the likelihood that some of those cancerous cells, because all of these membranes are lined with mucus producing cells, and some of those cancerous cells, if they form in those little tiny air sacs, then potentially when somebody does cough up and produce a sputum that can be analyzed, that could catch some of those cancers. But at best, it's a screening tool. And screening tools are something that, you're going to catch it in maybe half the population, but there's still going to be half the population that wouldn't have the cancer be picked up by the screening tool. If there are other signs and symptoms that the patient is having some sort of an associated malignancy, then a more invasive process is going to be required. And that may very well be where the patient has to have some sort of a biopsy. Now, if this is my thoracic cavity, and you guys all already know I'm not a whole heck of a lot about drawing, but again, this ends up being my thoracic cavity, and they may have to go through the ribs with the biopsy needle to be able to get to the cancer and actually take a small sample of that tissue, and then by using the microscope determine if there are in fact cancerous cells present. Now, that can lead to obviously there's the surgical procedure itself and the extraction of the biopsy tissue and the process where they have to analyze the cells. So that ends up getting into a pretty technical procedure. And then just for the biopsy itself, which of course has to be coded properly, and then ultimately for the analysis by the cytologist to decide whether or not this is a cancer, or in fact this is maybe a benign tumor, or maybe it's not even a tumor at all. Maybe it's something else. Maybe it's scar tissue from, I don't know, pneumonia or something years and years ago. But again, that is something that creates quite a chore in terms of the actual coding. If it comes back that it's non-cancerous, then obviously rule out diagnosis and stuff, that becomes kind of with the insurance company and everything, a tenuous a path to walk on. And of course takes, a lot of justification. Well, if it came back that the sputum test was negative, what was the rationale for going to this next step? Well, now that's come back negative as well. Was it something that this test was really warranted, and are we going to end up paying for it? And so again, that can be a very tenuous path to walk, but at the same time, it may very well be necessary. Um, in this day and age, of course, of defensive medicine, with physicians being so worried about litigation, they will order more tests than what they would have years and years ago. They would have gone more by intuition and what their experience had led them to believe, whereas in this day and age, uh, everything is test, test, test. So hopefully that sheds a little more light on your question that you had.
Yeah, yeah. So if I'm coded now, according to that picture, I really am not at that lung tissue if I'm outside of that area that you have on your diagram. And
Right.
if they take anything out of that tissue or ask for whatever it is, that is not really considered lung. So we can't
No.
code it as a lung virus.
Right. Right.
It's not. You got tags on that. You got denials, big denials on that.
Yeah.
So I haven't gone over that. It wasn't. I guess it's not a lung biopsy, or what was it? A lung biopsy versus what was the other? Well, they had bronchoscopy and lung biopsy. Oh, okay. Okay, so that means it's going to come up to a code. Let's say you can. It means you've got some lung. If you actually didn't get any lung tissue, how can it be a lung biopsy? Right. It has to be something else. Okay. So now you have to be able to, if you code it the way it's supposed to be coded, and someone says this is wrong, this was a bronchoscopy and a lung biopsy, you can say no. Here's why. Right. It didn't go. They didn't get the tissue. They got something else. They don't got tissue. Yeah, but then when they go in there and look, they like to take tissue. They can go to take a biopsy, but they have to go through that. Mm-hmm. So you coded it that. The coders coded it as a bronchoscopy and a lung biopsy when it actually wasn't. So when they did the audit, it said they told you're wrong. So they got a 45% accuracy rate because they didn't code it correctly. But did they not take tissue? They didn't, no, because they didn't get the lung tissue was okay. She showed on that drawing the lung tissue was here, fill out here. That's not lung biopsy. What lung tissue is this?
Yeah, at best you could probably say it was just a tissue biopsy at that point without, it would be, nondescript.
You just have to be careful because that's what it's specificity. And also what we're talking about, you're going to have more information. Actually, what's going to happen is I'm glad Professor Bernard is getting on to it because as I'm remembering what's on the audit, because they're also going to have the pneumonia and all that other stuff that she's covering, you're going to have, enough on it because he's explaining so you can visualize. So don't let somebody tell you that you're wrong about assigning a code if you know that this is absolutely the way it is. Come up with your justification. So if an insurance, because they have coders on the insurance company side, and they're looking, they're saying no, you saying yes. You remember the brachial ultrasound? You know how they got us. They love it. And I love when they think they love to get us. They ain't gonna get us this time. There's a lot of those in the tracheal, in the bronchial ultrasound. Okay, go ahead, Professor Bernard.
Oh, no problem. No, that's what this class is all about. That's exactly what I want it to do is help everybody out. Continuing with some of our terminology associated with cancer, biomarkers, biological markers or a product by which a cell can be identified. Cells all have antigens on them, and we, I believe, talked about antigens before. And again, an antigen, there are many antigens on cells, but each cell that's in my body is going to have a distinctive antigen. And my antigens, maybe like I've used in the past, we just say it's a K for my name, Carrie. And if a cell comes from a stranger, like for example in a transplant, all of their cells would have their markers, and my body would think it was foreign. But biomarkers in general are any of these different antigens that can be looked at and allow us to trace a cell. And that's the way we can tell if a cell comes from the testicles and it's spread to the lungs, it's spread to the brain. So again, that gives us an idea of where a cell originated. Bronchoalveolar, pertaining to the bronchi and alveoli. Fluoroscopy, examination of the structures of the body by x-rays. Grade, that's how we differentiate the different phases of cancer. In cancer pathology, a classification of the rate of growth of cancer cells. The higher the number, the more growth associated with the cancer. Mediastinoscopy, examination of the mediastinum using an endoscope. Pathology, medical specialty dealing with the structural and functional changes of a disease process. And I'm sure you ladies all know this from being in the coding field and being around healthcare professionals. Pathology is technically how you would pronounce it, much like it's spelled out phonetically. But everything, as you all well know, in the medical field gets run together real fast. It's not bronchoscopy, it's bronchoscopy. And they run everything together really fast. So when people get to talking among their colleagues, everything has a tendency to get run together real fast. Over the loudspeaker at the hospital, you'll hear Dr. Smith report to endoscopy instead of endoscopy. So again, that's why in some cases you hear a little bit of variation in how a word is pronounced versus textbook formation of the word from its elements versus the way it gets said in the hospital. Because you all know in the hospital everything has to be fast and it has to be accurate. Everybody's always in a hurry for everything. But getting back to our terms, pathology, medical specialty dealing with the structural and functional changes of a disease process. Pathologist is a specialist in pathology. Periphery, outer part of a structure away from the center. Peripheral, again, towards the outside. Radionuclide, radioactive agent used in diagnostic imaging. You know, this could be used in a whole bunch of different settings. Scintigraphy, recording of radioactivity with a special camera. Stage, definition of extent and dissemination of a malignant neoplasm. Okay. How big is it? And then is it starting to spread? Staging, the process of the determination of the extent of the distribution of a neoplasm. Whoops. Thoracoscopy, examination of the pleural cavity with an endoscope. And virulent, extremely toxic or pathogenic. Latin for poisonous. Virulent is poisonous. Okay. Treating of cancer. Of course, surgery. Again, surgery has to take into consideration not just carving out the cancer, but also making sure that any surrounding cells that the cancer cells may have spread to, metastasized to, are also removed as well. So again, that gets to be quite a tenuous situation. Radiotherapy uses radiation, and one of the types of commonly used forms of radiation therapy if you scroll down, is the stereotactic radiosurgery. That's starting to be very common. The Gamma Knife, Cobalt 60 Cobalt 60 based machine called the Gamma Knife, and basically instead of sending out a broad beam to destroy the cancer, which also in turn destroys good healthy cells, what the goal is with the Gamma Knife is pinpoint destruction of just the cancerous cells. And one of the ways they actually do that is to deprive it of its blood vessels. That in turn causes the cells to starve to death from lack of nutrients, and also lack of oxygen, which doesn't allow the cells to undergo their normal metabolic processes. So that means the cancerous cells have to quit dividing. Brachytherapy in our word bank, radiation therapy in which a source of irradiation is implanted in the tissue to be treated. Chemotherapy, treatment using chemical agents. Chemo, of course, is relating to chemicals. Hyperfractionated, given in smaller amounts and more frequently. Again, that's one of the ways that radiation or various types of chemicals may be introduced to the body to try to destroy the cancer. Small amounts, but more frequent. Some forms of treatment may actually have the patient go 5 days a week for different types of therapy. Very small amounts, but all the time. Lobectomy, surgical removal of a lobe of the lungs. And again, that's obviously going to be common with lung cancer. Remember, while we're on that subject, our lungs are going to have, our lungs, of course, are in our thoracic cavity. And our right lung actually has 3 lobes. Whereas the left lung, because of the way the heart sits in there among the lung tissue, there's a little cardiac notch, and so the left lung only has 2 lobes. And so when we talk about a lobectomy, obviously there are 3 lobes that could potentially be resected in the patient that has lung cancer if it's a right-sided cancer, and only 2 lobes potentially that could be removed if it's a left-sided lung cancer. Let's see. Photodynamic. Use of light-sensitive drug with a laser beam to destroy cells. Pneumonectomy. Surgical removal of the whole lung. Pneumono is a combining form that means lung. Radiation. Radi means X-ray radiation. Again, very common to hear the term radiation. Treatment with X-rays in this case. Radiotherapy, treatment using radiation, I should say. Again, radiation is related to X-rays. Regimen, a program of treatment, okay, from the Latin word that means direction. So what direction is the treatment going in? In other words, what's the treatment regimen? And segmentectomy, a surgical excision of a segment of tissue or organ. Okay. All right, and that's our chapter 21, or excuse me, chapter 20. Does anybody have any questions? We all hanging in there?